Okay, so I'm going to move on to the second topic, which was also a full session here in Stockholm. And I'm just going to give an overview of the status of MRD testing. I think that obviously we're pretty familiar with MRD testing now. We have the two methods that can be used. We've learned for sure that sensitivity at the 10 to the minus 6 level, the 1 in a million level, that really does make a difference in terms of a better PFS and anticipated survival outcome. And so trying to get to that level is definitely important in a clinical trial setting. What we also heard is that there's a pretty mixed perspective about how we should implement this in our clinical setting at the present time. And so I think we can probably just jump straight to the questions here, the key points. So as far as clinical trials, Sagar, how do you see the impact of MRD testing in clinical trials right now?
Yeah, I think there's no question that MRD has pretty important prognostic implications. Patients that achieve that level of depth of response have better PFS and long-term overall survival. I think how do we use this further on to make changes in therapy is really a subject of big debate at the meeting in the last day or two. And what I thought was really striking was the level of discordance amongst our members.
Yeah, 50% split actually.
Right, which was I think speaks to the level of evidence we have to support its use one way or another in terms of decision making. One area where I've got a little bit of concern in terms of interpreting outcome data with MRD really revolves around how patients were maintained in many of those trials, because we know that maintenance can impact PFS and OS potentially independent of MRD negativity.
Absolutely.
So, for instance, if you've got a high-risk patient that may not be MRD negative, but they're on a U.S.-based risk-adapted maintenance, like RVD, for instance, that our institution has piloted for a while, MRD may not mean the same thing in that patient as it does a patient in Europe who receives Len alone as maintenance with high-risk disease. So I think we have to understand some of those subtleties.
Yeah, I think it was pretty clear from my listening that people are uncomfortable to start to make big decisions based on the testing as of now. Mm-hmm. So what do you think?
No, I completely agree. I mean, I think it's critical that we do this kind of testing so that we can better, almost like mass spec, right? If we can diagnose the disease more accurately, follow it more accurately, and now we can more clearly assess how deep someone's response is. You want to know that their disease is gone down to that level. But I agree, there's a tremendous danger of making major treatment decisions until we know, even if it might predict that someone's going to live longer, which kind of makes sense. The deeper response you get, the longer it should be. It doesn't necessarily mean that we want to make a change in treatment. You know, we know about 15% of people who live the longest with myeloma. I mean, it's not majority by any means, but 15% of those people actually never even get a deep response. They go back to some kind of MGUS-like state. So we want to be careful, because I think the danger is we can either over or under treat these people. We might say, oh, you got MRD negativity, great, let's stop treatment, when in fact maybe that patient really needed it. By contrast, we might say, uh-oh, you're MRD positive, you need more, you need more, you need more, when in fact maybe they just need to stay on what they are or less. So I was actually encouraged by the end of the summit with the discordance that, you know, I asked that audience question and people were totally split on it. But I think by the end people recognized that we have to do trials that whatever depth someone gets to, then we randomize to the two options of either going on to something different or stopping, and then looking after. But I'd be worried if a patient listens today and says, well, you know, I listened to Dr. Lonial and they said I'm MRD negative, so I can stop treatment now. No. I don't think we're ready to make those kinds of decisions.
So I think it was very encouraging for everyone to see the menu of trials where there was randomization both for MRD negative and positive. As you say, MRD negative, maybe those patients are responding, need to stay on treatment. And then MRD positive, we're not quite sure what to do.
Yeah, really. I mean, I think it's sort of we're a victim of our own success to a certain extent. I mean, you remember the SWOG criteria where CR was a 75% reduction in the M protein, right? Exactly. We've gone 180 degrees in the other direction, saying now 1 in a million is what we really are shooting for in many patients. I think the other piece that was brought up very nicely in the discussion by the working group was the importance of imaging as a partner to MRD detection.
Absolutely.
Because, as Bart has been saying for years, it's great you're making the M protein go away, but what else is happening that may not be making a protein?
Yes, yeah. The combination with the PET CT in patients who may have extramedullary disease, yeah. So that comes around to, so how are you using this in clinical practice in the meantime, Sagar? What were you doing?
Yeah, I think we're collecting data right now and trying to analyze it in the context of a risk-adapted maintenance approach and what does it really mean. At least I'm not using it for immediate decision-making processes. Particularly, I think one of the concerns is just because you've reached MRD negativity, almost all the trials we've looked at don't necessarily show a plateau, meaning that you've achieved a point where you can stop therapy reliably.
Right.
And so until we have that data, I'm a little hesitant to use it to make a decision.
Right. So do you feel the same way?
Yeah, no, actually I feel identical. I mean, very much so. We collect it so we can have a big database and then later on look back. But I think it's very dangerous to make a treatment decision. Now, we kind of make treatment decisions based on depth of response already. You know, if someone, let's say, has had their transplant and you're getting ready for maintenance and there's still a lot of disease there, you might approach that differently. But I think when we're down to the level of MRD negativity, if I've got someone who's in pretty well a complete remission or close to it, whether they're MRD positive or negative, it's not going to change what I do. And I think that's important because otherwise we're going to be hurting our futures by making these decisions and not be able to look back and objectively know, was that the right decision or not?
Right. I do hear more decisions being considered when patients are MRD positive. And I think that the opportunity to maybe study and change treatment is there maybe a little bit sooner. We'll be able to make those interventions.
Sure.
And now as we tend to be treating people longer, it's part and parcel of that same discussion. Like we tend to in the US give maintenance for all the time until someone relapses, unless of course they have real difficulty with the drug. Whereas in some of the European countries where they may stop at a certain point, that's where that MRD positivity may influence them to keep them on it longer. But I think in general, we're treating most patients at least after transplant until their disease comes back.
And some of this relates to the treatment at symptomatic relapse versus treatment at biochemical relapse.
Yes.
This takes that whole question to another level where just because somebody goes to 20 to 50 copies, are you going to start treating them now or change their therapy? When we're not even sure, and that was another discordant discussion in the working group, whether biochemical versus symptomatic relapse is the right time to go.
Right. And actually, we're pretty excited. Within the Black Swan Research Initiative, Alberto Orfeo, he presented data about studying cells in the blood, and he showed data for the first time that if you have clonal plasma cells in the circulation, even in a patient who's in complete remission, that indicates a shorter remission time, and you would be, with that information, more comfortable to intervene early, because you know it means something.
Right.